Hello, and welcome to Cutting to the Case. Today we have Dr. Jesse M. Ehrenfeld. He's an anesthesiologist, health services researcher, military veteran, thank you for your service, and former president of the American Medical Association. He served as the 178th president of the AMA, becoming one of the youngest physicians to lead the organization in recent decades. A graduate of the University of Chicago and the University of Chicago Pritzker School of Medicine, Dr. Ehrenfeld completed his anesthesiology training at Massachusetts General Hospital and Harvard Medical School before joining the faculty at the Medical College of Wisconsin. His research is focused on perioperative care, healthcare information technology, patient safety, and the use of digital tools to improve clinical outcomes. In addition to his clinical and academic work, Dr. Ehrenfeld has served in the United States Navy Reserve and has advised healthcare organizations on issues ranging from physician burnout and workforce shortages to artificial intelligence, digital health, and healthcare policy. As president of the American Medical Association, he led the organization during a period of rapid change in medicine, including the emergence of generative AI, growing physician workforce challenges, and ongoing debates about healthcare access, reimbursement, and the future of medical practice. Today, Dr. Ehrenfeld continues to work at the intersection of medicine, technology, leadership, and health policy, helping shape how physicians and healthcare systems adapt to a rapidly changing healthcare environment. Thank you so much for joining us.
Oh, Cameron, thanks for having me. This is gonna be a fun conversation.
Yes, yes. I wanted to start out with a question that I think is on everyone's minds, which is what kind of healthcare problem do physicians understand very well, but policymakers often misunderstand? And I think you're a very good person to ask this, being both.
Look, when I got into my role at the AMA and I, started my time in leadership and was out representing physicians all across the country, I think I still kind of half believe this sort of story that we tell physicians like during their training that I'm sure a lot of your listeners have heard, which is that, um, if you're struggling, if you're exhausted, if you're feeling burnout, that the fix is to be like a little tougher
Mhm.
and a little more resilient and, take a pause, rebalance, take a wellness module, do some yoga. But I'll tell you, by the time I finished my journey at the American Medical Association leadership, I didn't believe that anymore. And I don't think I ever will again, because as I was out all across the country, speaking with physicians in more states than I can count,
Mhm.
sitting in hospitals, talking to folks in break rooms, I kept hearing the same thing over and over and over from physicians at every career stage. They weren't weak. They were some of the most resilient people I have ever met. It was the system that was breaking them.
Mhm.
And the day-to-day challenges of getting through your day, dealing with the inbox and prior authorization and just the slow drift
Mhm.
of the work away from the patient and towards the computer screen.
Mhm.
And so my thinking really changed. We don't have a burnout problem.
Mhm.
We have a broken systems problem. And for years, I've seen it, I've felt it. We've been asking individuals to absorb this like structural failure. And once you see it this way, you stop handing out, the meditation app and you start thinking, how do I reform and change this system that we drop incredible people, resilient people into caregivers who want nothing more than to make a difference in the lives of their patients.
Mhm.
Uh, and then they just get broken.
Mhm.
And so that entire reframe is probably the most important thing that I really saw and understood as I was leading the AMA and trying to advocate for the physician community.
Mhm. Yes. And about advocacy, I'm very curious as well. What kind of issues keeps healthcare leaders like yourself awake at night that the public rarely hears about?
There's so much out there, and you know, I'm just about to move from Milwaukee, Wisconsin to Washington, D.C. And um, I'm a pretty connected person. Led the AMA, a lot of friends in healthcare, have a lot of connectivity to health systems and CEOs. And so as we're, preparing for the move, of course, we need a new set of doctors.
Mhm.
And I get all my care through the VA system. I'm grateful for that. I believe in the VA system. I've made that active choice to stay in the system, even though I've got really good commercial coverage and could go anywhere in the country.
Mhm.
But my husband is not a veteran and not eligible to do that, and so we called a practice tied to a big system in the area. And yesterday they called us back and said, yes, we can get you an appointment. It'll be March of 2027
Mhm.
when we can get you in to see a new primary care doctor.
Mhm.
And that challenge of access is real, and people feel that in different kinds of ways. And unfortunately, just because you have insurance coverage doesn't mean that you have access. And the pressure on the entire system, as people are living longer with more chronic diseases, there's more work to do, just gets compounded. And I really believe that the only way out of this mess is by adding capacity through the use of digital tools and AI. And I spend a lot of time doing that in my current work in my day job at ADOC. But I think people don't always see that, and they think that the system will take care of them when they need it. And unfortunately, increasingly, that's just not the case for the average American.
Mhm. Yes. And you mentioned ADOC. I'd be very pleased if you could share what you do there now as the former president of the AMA for our audience as well.
Yeah, so I'm the global chief medical officer for ADOC. We're one of the largest clinical AI companies in the world. We support decision making and image analysis through AI tools. The company is a 10-year-old startup. We have tremendous scale. We are live in more than 1,700 hospitals and healthcare facilities, 44 states in the US, 19 countries. Every month, we see roughly 10 million scans, patients that we touch, and the impact of the tool is profound. And that's why I joined ADOC. Our image software basically is able to support workflows, support physicians and other clinicians, radiologists, ER docs, intensivists, hospitalists, as they are taking care of patients by enabling near real time instant triage of images. Let me just describe to you what this looks like. In my healthcare system and a lot of systems across the country, if you arrive in the emergency department with signs of a stroke,
Mhm.
and you get a CT scan of the head to look for a bleed or a clot. If our software is running, as soon as that image hits our servers, and it's a matter of a couple of minutes, you know, um, we analyze it.
Mhm.
And then we can flag abnormalities. We can help triage that study, elevate it in the treating clinician's queue, so that it's not 20 scans down, so that the stroke team, gets an instant notification on an app on their phone if there's a bleed. And when that kind of triage software is active, we're able to time treatment to support clinicians, not replace them, in ways that are very integrated and sensitive to the workflows. And not a week goes by that I don't hear from physicians across the country about very specific instances, very specific patients where the software made a difference. And that difference is often the change between life and death.
Wow. Wow, that's incredible. And so often it comes down to split second decisions when you're managing patients. Like really you get the imaging, and if you're in a patient room for too long, you miss that image. So this is just incredible, incredible software.
And and especially, you know what it's like. A lot of your listeners know what it's like at 3 in the morning when the ED is busy. There are a bunch of traumas that have come in, and things don't get seen in a timely fashion. Something may be overlooked, or maybe not even be recognized until the next day. And that's where these algorithms are incredibly powerful
Hmm.
in supporting that real-time decision making when the patient needs it. And
Hmm.
we've seen it over and over. There's a physician um, down in Georgia, and he emailed me recently about a patient who came into an outpatient imaging center, and this is a classic example, and we've seen this many times over. And the scenario is something like this: a patient who had been through chemotherapy, cancer treatment, had come in for a routine outpatient follow-up CT scan. And the patient was maybe a little short of breath, but didn't have substantial symptoms.
Hmm.
Had their scan an outpatient imaging center in a rural place. And typically those scans, my health system, they're read about a week later because we're always backed up. It's an outpatient scan. It's not prioritized as an urgent need. Well, this patient had a massive pulmonary embolus sitting on their CT scan,
Hmm.
and our software flagged it immediately,
Wow.
notified one of the radiologists at the health system who saw it, pulled it up, and got that treatment organized for that patient pretty immediately. And it's impossible to know exactly what would have happened to that patient, but likely they may not have had a positive outcome if they went home, got in the car, and a week went by before that PE was noticed by anybody. So again, really powerful when you think about what these kinds of systems can do at scale. And that's what's been such a fun journey for me to pivot from my work in academics as a senior leader in medical school to now being on the technology side.
Yes, and you're very humble to say, I wonder what would have happened. I think a lot of our viewers know what would have happened. But
Yeah.
yeah, yeah, that's what an incredible story. And I'm sure you have hundreds of those stories coming in all the time. Um, yeah, about just catching. I mean, imaging is so critical. And I mean, doctors are just bombarded with so much information at once. Um, and I was thinking about this, and I was thinking about you have your head very firmly planted on the trajectory of like where innovation is going in society. And so I'm very curious, um, what's the closest thing medicine has today to the internet in 1995? Clearly important, but we don't really appreciate how much it'll change everything. And I would encourage in the response to kind of also think outside of AI as well, or in terms of some kind of other aspect as well as AI.
Well, look, everybody today, if you ask them that question, they'll say AI.
Yeah.
And look, they're not going to be wrong, but I think that they're describing the tool, and they're missing the transformation. And
Mhm.
the real story today that I think we'll reflect on over time is that we're entering an era and a moment where medicine finally stops accepting preventable harm as
Mm.
kind of the background cost of doing business. And there's a number that frankly should keep everybody up at night who's listening. There's estimates, there's incredible work out of the Armstrong Institute at Johns Hopkins that suggests that nearly 800,000 Americans die or are permanently disabled every year because of diagnostic error.
Mm.
The wrong diagnosis, the misdiagnosis, the delayed diagnosis.
Mhm.
And so for like much of medical history, that harm has been invisible, right? It's happening one patient at a time. It's happening behind a closed door. And we all sort of tell ourselves that it's a tragic exception and we're numb to it.
Mhm.
What's changing now, and this is where AI comes in, is that we can finally start to see it. And we're going to be able to measure it at scale and find those patterns and catch the miss before it comes a catastrophe. So I think when we look back at this moment, I don't think anybody's going to write that, wow, the computers got smart. I think ultimately we're going to see that this was the moment that medicine turned and faced its own error rate honestly for the first time, and then started driving it down. And AI becomes the instrument, and confronting that preventable harm is the transformation. And I spend a good part of my forthcoming book, which will be out in February with Forbes. It's called Prescribing Healthcare's Future, on exactly this, and why the real story of this era, it's not the arrival of the technology, but what we choose to do with it.
Hmm. It's we're really at a crossroads here, and everyone's talking about the technology, but I mean the application of the technology and all the unique and highly incredibly original ways that it's being implemented already through AI doc. Um, it's just it's so inspiring to see, and what an exciting time to enter medicine. Um, so, I wanted to also bring this back to the trainees because they're absolutely very excited about all these technologies. Now, what skill do you think that the the trainees of now will can try to hone that AI won't take away, that they could still bring to the medical field?
Well, look, I think it's important that anybody in training or in practice really builds fluency with these tools, with AI from day one. And let me be kind of precise here. It's not like learning to code. It's how do you ask good questions of these tools?
Hmm.
How was this model built? On whom? When is it wrong? And I think physicians who thrive are the ones, it's not the ones who are like building the algorithms, it's the one who can interrogate them and
Hmm.
decide when to trust it. And that's a learnable skill. And when I teach about this, I especially I do a lot with medical educators. I just did a 4-hour GME workshop at a large health system for all of their leaders. I
Hmm.
talk about this difference between the scout and the sniper. And AI is the scout. It's constantly looking, surfacing findings, looking for opportunities to execute care pathways. But then the physician is the sniper, making that ultimate decision about when to act, questioning the AI, questioning the output, understanding uncertainty in the models, and then making a decision. So that's the first thing. The second is I would take communication very, very seriously, probably earlier than I did if I kind of think back on it. We train people for like a decade to be brilliant, and understand all this medical knowledge, and then we're surprised when they can't explain a diagnosis to a frightened family, or have to, as I have done, explain an error that they made to a family, or make a case to health system board, or frankly write something that like a normal human wants to read. And so writing and speaking are not like soft skills; they're how impact travels. And anyway, it's an exciting moment. We as humans, I think, will always have an incredibly important role to play in the delivery of care, because of what we offer that the machines can support and augment, but won't ever replace.
Hmm. What an insightful answer here. And, you're really painting a very vivid picture of what the future will look like with all this technology. There's so much uncertainty about how it's going to be implemented. And, I was also wondering if you woke up in a hospital 100 years from now, what would you look for first
You
that
know, um,
changed?
yeah, it's interesting. I mean, I think hospitals will look very different. I think you know, different tasks that we perform, that I perform today, will be automated. I think we're all looking for that. And if you look at just sort of like the administrative use cases for AI, ambient dictation and scribing, and chart summarization, and going through thousands of pages of notes, those kinds of tasks I think will get easier and give us more time to actually hopefully focus on what matters most, which is the patient. And I'll tell you, um, I, I I think I'm a pretty sophisticated user of the electronic health record. Been in practice for a long time. I still see patients a couple of times a month.
Mhm.
I'm a pretty sophisticated electronic health record user, training informatics, my work in digital health. And yet, I was taking care of a patient, had gone through their chart. I'm an anesthesiologist. I'm going to pre-op them. This is for cardiac surgery. And I'm just about finished. I do my exam. I'm talking to the patient. I start to walk out of the pre-op holding area, and the patient says, "Doctor, one more thing." And Cameron, when someone says, "Oh, doctor, one more thing," what's going to happen? So I turn back around and I say, "Yes." And she says, "Well, I don't want what happened the last time to happen this time." And I
Mm.
said, "Oh, well, what happened last time?" And she said, "Well, I had a cardiac arrest in the recovery room." And I said, "Oh, yeah, I don't want that to happen either." So I asked her more about it, and I went back and I looked in the chart, and the only place in the entire record that I could find any notation about this was in a PACU nursing note. Now I don't know how your listeners are accustomed to going through a chart, but I don't read too many of the PACU, nursing records as I'm going through, my pre-op evaluation for anesthesia. But obviously, that was a critically important detail that I missed, that I'm glad the patient surfaced, that you would want a chart summarization tool to elevate and serve up to me to make sure that I have all the information that I need moving forward. And I hope that, however the healthcare system is organized in 100 years, those tools are precise, and they work, and they enable humans to be upgraded to have the best capacity possible.
Mm. Yes. Yes, and really that comes down to efficiency as well, not just accuracy. I mean, you're thinking about all of these questions of physician burnout, and
Mhm.
oh my goodness, if that patient didn't mention that to me, what would I have thought as an anesthesiologist? And I'm wondering if every physician suddenly gained an extra 5 hours per day after you implemented these technologies, what should physicians spend that time doing? Because just as some context, I was speaking with the CFO of Mayo Clinic and MedStar, and they were saying, if it becomes more efficient, they'll just lay on more work onto doctors, and they won't really have a
Yeah.
say over what to do. And so I'm wondering what the AMA's kind of policy strength is there um, in terms of lobbying efforts, or what there is for just general physician burnout. Because a lot of people say AI will reduce physician burnout, and others are saying maybe not. Maybe it'll
Yeah.
just increase
Well,
expectations.
look, if we just use the tools to pile on a whole bunch of work, then I don't think we've solved the problem. And I do worry about this concept of load balancing. So um, when I am staffing multiple cases at the same time, either with anesthesia residents, or if I'm supervising nurse anesthetists or anesthesia assistants working in a care team model, um, generally I may have one really complex patient with a lot going on. And then more straightforward work down the hall in the other location that I'm staffing. Um, if you peel off all of the really, really easy stuff, and I'll give you the anesthesia example, but you can imagine this across specialties and different workflows, and all I'm left with is the really intense work, then that will just actually further exhaust the workforce. Right now, I can load balance, right? I can have some cases that are more straightforward, healthy patients, not a lot of comorbidities. I'm not hanging blood and doing chest compressions. And then the patients that really, really need that exertion of energy and expertise, I'm there and I have the cognitive energy to do that. But ultimately, I worry about what that load balancing looks like in the long term as we sort of adjust workflows in care delivery teams using AI and other tools in the future.
Yeah, yeah. Load balancing is a privilege that we cannot afford to lose as a workforce.
Yeah.
Um, Absolutely. And, you know, If you could remove one part of modern healthcare entirely and rebuild it from scratch, what would you want to rebuild?
It's hard to say. I still think that there's a lot of low value work that we do. It's so complex. You would never build the system the way that it is designed today. I was speaking earlier this morning with an incredible physician leader who I'm trying to recruit to work with me, and we're having this deep conversation about the change in health insurance. If they end up, moving jobs. And, we're both, senior physician leaders. And for us to navigate the complexity of doing that is maddening. And unfortunately, we don't have the luxury of pulling the plug and blowing it up and starting from scratch. And that's why it's been so challenging to try to make these reforms that make it easier for people to navigate the system, not just have access and get the things that they need.
Yes. Yes. And I I guess also what's a problem in medicine that may ultimately require a different kind of doctor to solve? Do you think that there could be a new kind of specialty that emerges that's kind of in the same way that you have pathologists or radiologists who are kind of the doctor of doctors or the plastic surgeons who are the surgeon of surgeons? Might there be a new specialty that emerges that's an AI specialty like a fellowship or
Well, I think AI will infiltrate into everything, and I've said and I've been quoted many times that AI won't replace physicians, but physicians who use AI will replace those who don't. Right now we've run into this challenge that I can't keep in my brain everything that exists that could help me take care of a patient. That's the knowledge base because, millions of citations get thrown out every year. And, there's studies, and I can't give you numbers, but, it would take more hours than exist in a day for the average internist primary care doc to keep up with the literature. That's impossible. So we have to have these tools that can help us search and sort and find and elevate the information. And that's like the medical knowledge. Then there's the data on the patient. And patients have more and more and more data ever than available before. You put aside the basic labs and images and notes and stuff and add genomic information and all the omic information and then all the data from wearables that is starting to compound the order of magnitude of points of data that are available for any patient in any setting. And bringing those things together in a holistic way is just now exceeding the capacity of the human brain.
yes.
And so the only way to manage all this is to have tools that can help us. And I'm excited about what I think is going to be coming online in terms of different kinds of capabilities
Mhm.
that will allow clinicians to navigate that much, much more effectively than we can right now.
Wow. Wow. And you're absolutely right in terms of cognitive overload. There's just so much information entering medicine at any given time. And to keep up with all of the latest guidelines, like Open Evidence is doing excellent work here, keeping everyone up to date. I remember a statistic like something like the vast majority of doctors nationwide are now using Open Evidence. And
So they exceed 1 million queries from licensed clinicians, not only doctors, but other clinicians every day. It's massive. And that's only exploding. Yeah.
I mean, yeah, I've even noticed on the wards, like my physicians and my residents and my mentors are always asking, I mean, we ran into I was on infectious disease and we ran into a bacteria that they'd never heard of. And they asked Open Evidence, like, what is this?
Right.
We're in DC.
Right.
We think we see very interesting
Yeah.
things. So, um, it's fascinating. It would have and it compressed what would have been like a 2, 3 hour literature review into a nice,
Yeah.
concise, very beautifully written statement. So,
Yeah.
kudos to the team at Nejum and Jama, I believe, is also one of the. So, kind of. I I would like to kind of move forward into the future of medicine once again. And I want to ask a question about, I'm trying to get at, a lot of the conversations are hitting on artificial intelligence right now, But I'm wondering, what's a question about the future of medicine that no one's asking yet?
I think there's a question about who's advocating at the end of the day for our patients. And I think there's a lot of anxiety about physician autonomy and what our role is in defining the system of the future and what are we giving to companies and healthcare systems and those kinds of things. And that's where I think obviously I'm a huge believer in the role of physicians as advocates for the profession, for our patients, for our communities, and for the nation. And I think that is going to be increasingly important for physicians to lean into.
Mhm.
And obviously, that's what took me into my journey at the AMA with a lot of personal work and sweat and tears along the way.
Yes. And kind of looking forward as well, um, looking back 50 years from now, what idea about healthcare do you think people will find most difficult to believe was once accepted? Beyond the highly, concerning uh, race-adjusted GFRs and the pulse oximeters, and I wanted to ask that as well.
It's interesting. I do think that we'll wonder how on earth did we work without these kinds of tools. I really do believe that, and it's one of those things where when I started my anesthesia residency, it was not unexpected or uncommon for anesthesiologists or intensivists to put in central lines without ultrasound. It was not the standard of care. They were expensive. It wasn't universally available. And the training for using those tools hadn't taken foot. We know the data are clear that if you use ultrasound to place a central line, your complication rate, is much lower. And so I wouldn't dream today of putting a central line in without an ultrasound. It's a shift. It's a market shift that technology has enabled that has improved patient outcomes. And I think we'll see those kinds of shifts in all sorts of different ways with digital health tools, including AI and other algorithms that, when we look back, we'll go, wow, how on earth did we have a system that worked without these kinds of backstops?
Absolutely. Yes, yes. And when historians look back on this era of medicine, what do you hope they call it?
Well, I hope they see this like massive transition point.
Hmm.
And obviously, this is hard. It's hard for physicians in practice. It's hard for trainees. I have the privilege of sometimes being on site when a healthcare system goes live with ADOC and our tools and our algorithms. And I was recently at an academic center and we did sort of a lunch and learn, made myself and the team available to meet with folks and answer questions. And there were a lot of residents who came, not too many attendings. And they had two questions for me. One was like, what was it like being the president of AMA, which was, kind of fun. I'm always happy to talk about that, just because it's a little bit different and unique, and not too many folks get to meet an AMA president or former president, which was fine. But the other questions were all about the uncertainty of the future and will I have a job? What is this tool going to mean for my career in how I practice in the opportunities ahead? And I think, we're seeing that anxiety play out in all sorts of corners of society, in all sorts of professional roles. But it's real in medicine too. And again, I think that there is so much value that we as humans bring to the care delivery process that will only be elevated ultimately by these tools, but we're in this tremendous moment of uncertainty that we're going to have to sort of navigate as we figure out where that all lands.
Yes, yes, absolutely. And kind of to swing that question back around you, what was it like being president of the AMA?
Well, I tell people all the time, it was like my intern year in internal medicine at Mass General. I loved every minute of it. I was pretty good at writing the orders at the end. I learned a ton. It was exhausting, and I never need to do it again.
That's very humble of you to say. I mean, this is the final stage in anyone's training rather than the first stage, but
Yeah.
it's It's amazing how you framed that actually. And you seem to have this kind of humble posture of learning that you've brought to your whole career, that you're comfortable sitting with the uncertainty and growing throughout the process. And I think that's
Well,
so inspiring.
let me tell you a story that changed how I think about all of this advocacy and whatnot. And years ago, my older son landed in the NICU. He
Mm.
was born at 29 weeks. And if you ever sat next to one
Wow.
of those isolates,
Hmm.
you know that nothing else in the world, like in that moment, matters except for that tiny little person in front of you. And you would give anything,
Hmm.
um, to help that child. Um, you give your own blood. And as I was sitting in the NICU, here was the thing. I couldn't. I'm a physician, served in the Navy, was the baby's dad, was the chair of the AMA board at the time. But under the FDA's policy at the time, as a gay man, my blood was not welcome.
Wow.
Not because of anything to do with actual health, but because of who I am and who I loved, and a rule that was written in the 1980s, long after the science had moved on,
Hmm.
still told me that my blood was disqualified while
Hmm.
my child lay there in an incubator. And I rarely felt anything like that mix of helplessness and anger.
Hmm.
And so, we all have choices, and I had a choice in that moment. And this is the part that I want your listeners to hear.
Hmm.
I could let it stay a private wound, or you turn that and you fight it. And I turned it into a fight, and I used every platform I had through the AMA and well beyond to push on policy changes, because this policy was discriminatory. It wasn't grounded in science,
Hmm.
and it was turning away willing, healthy donors during, oh wait, blood shortages
Hmm.
that hospitals keep worrying about. And I'm an anesthesiologist. I give, almost more blood than any other specialist, in the house of medicine. So the full arc is that, took years, and a lot of people, not just me, but the policy got moved, and the lifetime ban became a deferral. The deferral got shorter. And eventually, the FDA threw out the blanket rule,
Hmm.
and replaced it with an individual risk-based assessment.
Hmm.
So you're evaluated on your own behavior like everybody else, instead of put into this category that you were sorted into.
Hmm.
And so the thing that disqualified me when my older son was in the NICU, that's gone. So, I get asked all the time, about advocacy and my journey in medicine and policy, and like, why do it? Like, why did I give so much? I'll never forget my son. We were on a family trip somewhere, and I traveled a ton when I was in leadership. And we flew home, got the cards in the bag, loaded everybody up, and then I went to hug my kids and say goodbye, because I had to go back through security to get on a plane to go somewhere else for the next day.
Hmm.
And he looked at me, and this broke my heart. He said, "Daddy, why do you have to be the AMA president?"
Hmm.
And the answer was, because the most durable advocacy is rooted in something personal,
Hmm.
something that actually costs you. And look, change is slow, and it's painful and agonizing, especially if you're the one waiting, but it is absolutely possible. You just have to be willing to push long enough, after the cameras leave, and ultimately get there.
Wow. Wow. What a beautiful story. I mean, that I am so sorry that you experienced that, and I can't imagine how that must have felt as a father. And the amount of personal growth that you've conveyed throughout this process is incredible. It's inspiring me right now. Um, and this idea of connecting advocacy to something very um, primal as a father. I will not let this happen. This is unjust, and who knows how many lives you've saved through pushing that forward. And thank you for all that you've done. Thank you.
Thanks. Yeah, it was also a very special moment. My husband and I, after the ban was finally lifted, went to our local blood center together and donated blood. And it's kind of a funny story. I was still in leadership at the AMA, and we decided that we would, publicize this. So they put out a press release, and basically every news station in town showed up with their video cameras, which was fine. Imagine you're the phlebotomist trying to start the blood draw on the president of the AMA with all these TV cameras around. Um, Not an easy situation. And so on in one of the TV clips, you can actually see me wincing a little bit as she's like fishing around in my arm trying to find the vein. And she said to me at one point, I'm sorry, doctor, I just don't think this is going to happen today. And I said, listen, you can do it. And this is really a moment where failure is not an option. Just keep going. And she got it. And I was able to donate. And obviously, it was a fun story.
That's a very anesthesiologist attending thing to say to her. Wow, wow. I mean, this is just incredible. And so we have the story of the why, but I think another question that a lot of our listeners are very curious about is the how. How did you end up in AMA leadership? How did you get involved? I know so many people are very politically engaged, especially here at Georgetown, being in DC with Dr. Fauci and all these health policy leaders, but they want to affect change, not just, show up to various Congress events and just be a
Yeah.
fly on the wall. How do you actively do it? And at what stage in the training? I know they're like very, broad-based answers. I'd like you, if you can, to be as specific as possible regarding like when you get involved, at what stage of training, who to reach out to, like all of the mechanics.
Yeah, I'll say kind of the uncomfortable part first, which is that like anybody who just sets out to be, AMA president as a goal shouldn't be the president.
Yeah.
The job is service, and the moment that you turn that kind of an aspiration or something like it, um, into a rung on a ladder that you're just trying to climb, like people can smell it,
Mhm.
and they know whether you're doing it for an authentic reason or not. And so what I tell people all the time, and I've been fortunate to mentor lots of students and residents and fellows and junior faculty, is get involved early, do it locally. I got involved in the medical student section at the end of my first year of medical school, my state society, my specialty society. There were some committees that nobody else, frankly, wanted to do. The Minority Issues Committee of the AMA local chapter. But it was a place for me to start and to learn. And Cameron, you'll never believe this. I'm an introvert. Like I am wired to be like the quiet guy in the back of the room. And so I talked about communication earlier in our conversation. I've had to learn how to put myself out there, how to communicate, how to, do a Hill visit, have a conversation with a leader at a health system. And, learning how to do that is actually how like all of this functions and is some of the most important work that you can do.
Wow. There again, it's this recurrent theme of personal growth as you spiral upwards in the trajectory, recognizing the deficiencies holding someone back and I'm sure that translates very beautifully into your mentorship efforts as you do with your students. This is really incredible. Um, I do want to be very respectful of your time. So
Sure.
I understand you've blocked off an hour. We're approaching, we have 10 more minutes. Do you have any questions or any further advice to share with our audience?
You know, um, I love taking pictures, and I've done some documentary work, which has been fun. My husband used to get so annoyed about this because he hates having his picture taken, and now I've got kids, so I mostly take pictures of them. But the thing that you learn when you're behind a camera lens is that the important thing in the frame is usually what everybody else is walking right past. And healthcare is full of that, like literally. And there are all these opportunities hiding in plain sight that don't have to be a moonshot, right? It's the gap between what we know works and what we actually reliably do. We've known for like decades how to prevent certain hospital acquired infections. There's a checklist. The evidence is overwhelming. Peter Pronovost, incredible safety leader, showed that you can drive these infections down to zero or near zero, and yet patients still get them. because we don't execute consistently. And I've said for years that the next breakthrough drug in medicine, I don't think is a pharmaceutical agent or a new biologic or injectable peptide. I think it's technology that creates reliable systems where we can execute consistently. And I'm excited to see what that's going to happen as we move into the future.
Absolutely. That's what a wonderful note to end on. I appreciate it. Yes. So, with that, I have no further questions. Thank you again for joining. This has been such an honor, and I am sure that our audience will be very grateful that you've joined.
Yeah, thanks for having me, Cameron.
Thank you. You have a great day. This is Cameron Sabat from Cutting to the Case, signing off.